I'm from Bulgaria. It's a great honor for me to be part of this interesting session. I will present you a clinical case of 85-year-old female. Risk factors only hypertension. She admitted in our hospital with acute strong chest and epigastric abdominal pain starting 45 to 60 minutes before hospitalization. On ECG, there was anterior STEMI and also severe left ventricular dysfunction from echo, mild mitral regurgitation, and small hyperechogenic shadow in left atrium. She was 45 kilos and the graphic windows was very good. She was also with cardiogenic shock and later with ineffective spontaneous breathing. So patient was intubated and put on invasive ventilation. We transfer her directly to the cath lab. And from history, there is a history of paroxysmal atrial fibrillation treated with amiodarone, no anticoagulant. This was the angio. We can see this terrible thrombus, subocclusive occlusion of the left main with very slow flow TIMI 1 to 0 in the LAD and TIMI 1 in the circumflex. Right with right dominant with narrowing without any critical stenosis. And situation was very dramatic. So what was the strategy? Should we put the intra-aortic balloon pump to wire LAD, circumflex, thrombus aspiration, or first balloon dilatation, then thrombus aspiration, and after that stent strategy, or just aspirate through guiding catheter? That's what we do. We decide to aspirate direct through catheter, and after that, this is the result. Perfect result. So there is nothing left, and this time we decide to, this is the thrombus. We decide to do IVUS and to exclude some plaque rupture or dissection, and everything was good on the IVUS. So there was significant hemodynamic improvement. You can see here with some reperfusion arrhythmia. And 80 hours later, the patient was extubated, but she complained of severe abdominal pain. And we can consult with the abdominal surgeon. Then we decide to perform mesenteric ography. And this was the result. Occlusion of superior mesenteric artery. We perform few thrombus aspiration, balloon dilatations. You can see here the thrombus. We recanalize the artery, but I think it was too late. So after procedure, patient was with persistent abdominal pain, and surgeon decided not to operate at this moment. There was no free abdominal fluid. He spoke with relatives. He explained the high risk of operation, and on the next day, the patient died. It was very sad. So, in conclusion, simultaneous embolism in left main and mesenteric artery is a very rare condition in clinical practice, and thus the diagnosis is extremely difficult. Embolic occlusion of left main is a life-threatening condition, and direct thrombus aspiration through guiding catheter should be or may be treatment choice. Full recovery in absence of stenosis is indication for IVUS to exclude plaque rupture or dissection. Mesenteric embolism requires treatment from team of interventional doctor, vascular surgeon, and abdominal surgeon. In our case, critical condition of patient due to acute coronary syndrome and the following intubation mask the clinical symptoms of second life-threatening embolization in mesenteric artery. And whenever we diagnose the embolism in one artery, we should think about another if there are any symptoms of ischemia in another region, or we should consider simultaneous embolism. And thank you very much for your attention.
Yeah, very interesting case, having two sites with thrombus and both sides having a huge, massive thrombus. And ultimately, the patient seems to have succumbed to the mesenteric artery thrombus rather than the coronary artery, left main thrombus.
Excuse me, I just want to know how many of you think that this was iatrogenic embolization? Because
So, we started
there
off...
is possibility, but we didn't remove the catheter from the left main.
So this is highly likely to be thrombus from the catheter.
But it's also highly likely to be
we started off
simultaneous.
at the beginning saying that you really have to open your catheter, let it bleed back, and if necessary take your catheter out. If you have any doubts at all, that you could be injected, it could be a stroke, it could be mesenteric, it could be circumflex. You have to be obsessive about having no thrombus in your guide catheter. And I think particularly using guide catheter, because you don't have any suction, really, there's more stasis. I think you should, at least with a thrombectomy catheter, you have negative suction as you pull it out, as you should. But with a guide catheter, I think the suction isn't so great because it's a bigger volume. So I think you should take the catheter out, and I'm absolutely certain this is.
So we take very good flow from the catheter, and the catheter was all the time in the. Okay. But
good lesson.
Yeah, very good lesson. This happens, sometimes after an angiography.
Sorry, because in patient's history, it seemed to be a strong abdominal pain before the procedure.
Yes, there was abdominal pain before the procedure, and I have seen, I have read about similar case with simultaneous embolism. So we discussed this in our cath lab. We decided that this is simultaneous embolism.
There was nothing in the left ventricle. Left ventricle didn't have a thrombus.
In left atrium, there was some shadow.
Okay.
Yes. Yeah. And she was with atrial fibrillation.
When did you get back the intra-aortic balloon pump? I can see during mesenteric angiography.
No, we didn't. We
didn't use balloon pump.
No, we didn't use balloon pump.
But you said you used?
No, this was the first strategy we were thinking about.
Oh, okay, you didn't use any balloon pump.
Then someone said, why don't you aspirate directly? And we didn't use balloon pump.
So what's interesting, of course, is if she had survived, and it's a shame because we would have had 100% survival for this session.
In this session, yes.
More than the 50% that was quoted earlier. But if she had survived, then how do you manage her 85, atrial fibrillation, and whether or not, clearly, in someone like this who you haven't put a stent in, then it's much easier. But of course, if you put a stent in, then you have to consider what strategy one would consider in this lady. And I guess the guidelines currently are suggesting NOAC plus clopidogrel in these patients rather than Coumadin and/or ticagrelor or prasugrel.
Yeah, like the redual PCI study. Yes.
Besides embolization from catheter, there may be another explanation for this case because the patient has had an AF, and there is something in left atrium.
Yeah, there was something suspicious in the left atrial
is
appendage.
Together or after that. But important issue in this case is that mesenteric embolization. I have experience of cases with such a embolization. When you going to pass the wire and give some embolectomy or something, there is a gush of distal embolization, and if is it time, there is a lag time of your procedure to there is extensive necrosis, and the chance of survival is very low in these poor techniques because mesenteric embolization is a very lethal situation, and it's not related, in my opinion, maybe not related to your procedure.
I mean, you make a good point, because I think when I do thromboaspiration, I aspirate on the way in. So I don't pass and then aspirate on the way out. I think you should be aspirating as you come out of the guide catheter, and you should do as many passes as you feel your catheter team will tolerate. and then
Take out the guiding
total,
catheter.
and others suggested 2 syringe falls, but you know we often don't get that.
Yes, but I think that if we remove the catheter, there is also a risk of embolization, and I don't think that this is iatrogenic because if we flush the thrombus again inside, thrombus will go into the coronary, not into the mesenteric artery.
Anything to add?
Was there, did you check celiac artery and inferior mesenteric artery as well? Celiac, inferior mesenteric arteries, all those arteries were clean?
Excuse me, I don't understand the question.
Did you, when you did the angiography of superior mesenteric artery, did you check the inferior mesenteric artery, celiac artery as well, and they were clean?
No, only the superior.
Some of them were visible.
There was aortography and mesenteric ography.
I mean, our chairman mentioned earlier on about guide catheter, and it's another example.
Yes.
There are cases written up, and I've used guideliner as a better way than the guide catheter. You've got better control and more focused aspiration using a guideliner than using a guide.
That's right. You know, it sucks out a good amount of clot. So I think we had a very interesting session of 7 or 8 cases. In fact, we also saw one of them presenting at least 8 cases. And we saw that all these patients obviously had a very catastrophic presentation, and almost every case had a good right coronary artery flowing very well to support it. A few had some collaterals going to the left system, making them survive. And one of the first things is to get the thrombus out by thrombus aspiration. And as we suggested that if it's a large body of thrombus, then these tiny thrombus extraction devices don't work, you know. Sucking with the guide liner or sucking through the guiding catheter is the way. And first thing is to restore the flow. Patient becomes stable. And at that stage, maybe if the patient has stabilized, hold on for some time. Pay attention to the antiplatelet therapy, give GP2B3 blockers, make the patient stable. And then, once the patient is stabilized, then we have to see what was the problem and fix that problem. And for that, I think intravascular imaging is very important to do a procedure which is long-lasting, so that if you deploy a stent, it is very well deployed and adequately sized and adequately apposed. And following that, long-term antiplatelet compliant patient, educating the patient is very important. And in this situation, wherever you can, use a drug other than clopidogrel, like something like ticagrelor would be the preferable drug. But if you don't have it, then prasugrel, ruling out those patients with high bleeding risk, like elderly, thin build and history of previous stroke. So I think it was a very educative session. We saw great cases and great outcomes. Thank you very much.
Yeah, the real message, the other message, I think, is these are complex cases. They come in very different forms. And I think if you're an inexperienced interventionist, calling a senior colleague, having a strategy, working it out, making sure you understand all the aspects is really important, because if you get it right, you optimize their chance of survival. But you don't have to get it very wrong for them to die. So you need to be absolute.
Teamwork, yeah.